higher functions are prefrontal cortex. Most of the higher functions are performed by the prefrontal cortex in association with the various other areas of the brain. Now, you may be wondering why I have put this skull here. This is the skull of one of those famous patients, Phineas Gage. All the information we have gathered up till now regarding the prefrontal cortex are from this patient. This is Phineas Gage, who is reconstructed and whose image is there. And he moved with this rod. He's holding this rod. No, first he submitted this rod to the museum. Later on, he retrieved it back, and he was carrying the rod all through his life. He was a proud possessor of this rod, and this rod had changed his life. Phineas Gage is a very intelligent, hardworking, industrious or illustrious man, a foreman, who was working in the construction company, and he was working in the railways of the United States of America. In one fateful day, he met with an accident, or there was a blast, and because of the blast, he opened the mouth, and this rod went through his mouth and passed through the skull, like that. And after the accident, he was awake. He did not lose consciousness, and he just carried this thing, and he himself went to the doctor. And he was talking and he was walking, and there was no behavioral abnormalities immediately after. But after some days, because the doctors were trying to treat him, because this metal rod has pierced through the brain. And when there is if you are going through this Wikipedia and this Phineas Gage, you will see the details of his case history. They're recorded in the Wikipedia. And he was having a difficulty maybe for a month or two. So there were abscess, infection, and all those things. Then he recovered. Then after recovery, previously he was a thorough gentleman, intelligent, very social, and acceptable to everyone. And his work was commended, and he was one of those good workers. Now, after this thing, he could not do the work as expected, and in addition, he has certain behavioral abnormalities. Often used to become agitated, and his intellectual abilities were now destroyed, and his emotional, these things were labile, and he was having all antisocial type of behavior. He lost the social consciousness, and he was sort of becoming a sex maniac, and he was all the time looking at the pornographic these things and using the pornographic languages. And then the doctors, after they examined, and after his death, they examined, there was the frontal lobe which was disconnected, and then there was a lot of things analyzed. This is Phineas Gage. Now, looking at the Phineas Gage, the enormous information was accumulated regarding the prefrontal lobe. And now come back here. Before we go to the prefrontal lobe as such, we try to examine what are higher functions. Higher functions are divided into two components. One, cognitive functions and behavioral functions. The cognitive functions include intellectual functions, that is performing task, arranging the task, and planning the task, and doing all that in appropriate situations in a time-bound manner. That is the intellectual function. Or recalling the already learned or a known knowledge, or retrieving the known knowledge and applying it for the use of our own. So that means tomorrow we are going to be doctors, and you retrieve all the information you had learned through the 4.5 years or these things, and then you apply. That is an intellectual ability. That's a cognitive ability. So that means these cognitive functions include memory. There are different types of memory. Maybe I would take on Saturday that memory is also a component of the cognition. In addition, the cognition also is associated with the speech and the language. That means the communication. It's the communication. And the communication, the language tells the effectiveness of the communication. Because if you have to use, suppose whatever language it may be, whatever the whether it is English, Hindi, Kannada, or Telugu, or whatever, so you have a sweetness, the very nice language spoken by the individuals, and that is the intellectual ability, that is the cognitive component. Then the perceiving the entire universe as one, comprehending it, abstracting it, and trying to know about what is happening. That is a complex perception. That is a part of the cognition. Then orienting oneself to the current situation. That means we are now in the midst of this pandemic, COVID-19, and we are trying to orient ourselves. We are trying to be in whatever the expected norms of the society, trying to be at home, trying to observe certain restrictions or disciplines, and trying to achieve. That is the orientation. Then attention. That means you are attending to particular problems. Say, for example, now you are listening to my lecture, so you have to have the attention. That is one of the cognitive ability you have. Then judgment. Judgment comes to decide between the two things, to decide whether to do or not to do. So that judgment, or if I do, what I will have or what I will get, and how I am going to be benefited, how I can make it easier. So these are all coming in the judgmental aspects. So then this is a part of the plan. That means you, to achieve that, you need to plan, you need to take a decision. And all these things are a cognitive behavior of the higher functions. Coming to the behavior, behavior is manifestations of all those actions. The manifestations, that manifestations of the intellectual functions. Manifestations are bringing out the memory. The manifestations are speaking or using an appropriate language, and trying to give the complex perception, or trying to orient yourself to the current situation, and be attentive and judge according to the current situation. So these are the manifestations of the cognitive functions, and this would manifest as the personality. So that means we have a different type of personalities. So maybe you may be having a type A personality, type B personality, or introverts, extroverts, or mixed, whatever. So that means the personality is a part of the behavior. That is one of the higher functions. Then traits. That means we carry certain amount of behavioral things along with each one of us. So those traits and our psychological makeup and all these things form the behavior. Now, the cognition and behavior are the higher functions. And if you are looking at the cognition and behavior and where they are set in this map. So this is the map of the brain. You have the brain there, the cortex, cerebral cortex. And in this cerebral cortex, we know that this is the central sulcus there. So the post-central area, we know that this is the somatosensory area. This is somatosensory area. So then before that, the precentral area is the motor area, which governs our the muscle activity. This is all sensations. So then this one governs the, or mixes all the visual, auditory, somatosensory inputs, the somatosensory association area. So that means this is a frontal, and this is a parietal area, and we know about these, and we have talked about these. And this is occipital cortex. This part is the occipital cortex, that is for the vision. And this is auditory cortex, that is for the hearing. This is the temporal lobe, that is temporal lobe for the limbic systems. And you have this blue area here. This is a Wernicke's area. This is for a language, sensory component of the language area or the speech area. And the remaining, some of these things, we have the insular cortex there. That is again associated with the behavior. And if you are cutting it across, we have the cingulate cortex, that is concerned with the affective. Now, where is this cognitive component? The cognitive component, if I were to tell the higher functions in terms of the cognition and behavior, where they are mapped or where they can be traced in this map, and it is this part of the brain, we can put the higher functions together. Okay, so this is a motor cortex, 4, 6. Now we have a 8, the frontal eye field, 9, 10, 11, 12. So some areas. So now if I go further, so we will just proceed. So that means we know about these things. Today we try to look into this prefrontal cortex. This is a prefrontal cortex. This is also a frontal cortex, and the prefrontal cortex is before the premotor area or the supplementary motor area. Whatever the components coming anterior to it is the prefrontal cortex. The prefrontal cortex. So now, if you are looking at this is the area anterior to the premotor area. This is the central sulcus there, the premotor area, anterior to the premotor. This forms the premotor area. And these colored ones, this violet, the green, and the blue. So they represent the parts of the prefrontal cortex. And they have the areas, Brodmann areas number 9 to 12. 9, 10, 11, 12, something like that. You are coming in this way. Then 45 and 47, they come somewhere here. And then we have those areas. That is the Brodmann areas. Now, they can be divided into 3 parts. The prefrontal area can be divided into 3 parts. The first part is the dorsolateral prefrontal cortex. This the violet area. This dorsolateral prefrontal cortex. Then we have this green area. This is the medial or a polar prefrontal cortex, and this represents the Brodmann area number 10. So then we have this blue area. This is the orbitofrontal cortex. This becomes a part of the limbic system. The cellular structure of these areas, thin, and it is mostly granular. If you are, that means if you are looking at these areas, this is only the pyramidal cell layer. That means pyramidal cells. And if you are looking at these areas, these are granular areas, or a conio. So that means the dust-like appearance. Now this is also a sort of a thin and granular cortex. And the density of pyramidal cells in layer 5, that means pyramidal cells, are those which gives out the information to below the subcortical levels, distant areas. They have a less number, their size is smaller, and they are less dense. This is what the anatomical location of the prefrontal area. Am I right? Okay, dorsolateral prefrontal cortex, the medial prefrontal cortex, and orbitofrontal cortex. Now, recently, there are nearly 5 to 6 areas have been mapped out. So some people, they try to project 5 to 6 areas. They are nothing new than what we have seen these 3 areas. We have this dorsolateral prefrontal cortex, this area. Brodmann area number 9 and 46, the dorsolateral prefrontal cortex. Now we have the frontal polar area. This is the medial prefrontal cortex. So this is the frontal polar area. BA stands for Brodmann area number 10. So now these stars indicate the orbitofrontal cortex. These are the orbitofrontal cortex, the number 11, 45, and 47, or maybe some of them inside. They will come here. You have 11, 24 are coming, and some part of 32 they are coming up, 25, 32. So that means here it is mentioned this anterior cingulate is 32 and 34. 32 and 24. This is anterior cingulate. So orbitofrontal cortex. So now this area. Then comes we have another area. This area is this one is a subjunal area. That means orbitofrontal cortex is again subdivided into subjunal area. That is a number 25. So now then we have the Broca's area here. This is the number 44 is the Broca's area. This Broca's area is a speech area. We will not, because it is exclusively for a motor speech area, we are not going to deal with. So that means we have one, the dorsolateral prefrontal cortex. Number 2, the polar or a medial prefrontal cortex. Number 3 is the orbitofrontal cortex. So then number 4 is subjunal cortex. The remaining is usually they are not included in the prefrontal cortex. They have been defined with the Broca's area. Now if I come back here, the dorsolateral prefrontal cortex and the frontal pole, that is the polar area, medial prefrontal cortex, then orbitofrontal cortex, subgenal cortex. The anterior part of the anterior cingulate cortex is also included in the prefrontal cortex. But part of the anterior cingulate cortex joins with the orbitofrontal cortex. So these areas are almost in close association. The Broca's area is separate. These are parts of the prefrontal cortex. So I am just taking with those three things. That means a dorsolateral prefrontal cortex, the medial or the frontal polar prefrontal cortex, and the orbitofrontal, because I put all these three things as orbitofrontal. Now let us see what is this dorsolateral prefrontal cortex is about. It's an important part of the, very important part of the frontal lobe. And you must have seen, your elderly people are telling, maybe you must have heard that now you are still young, you will not understand these problems. That is true in the sense the dorsolateral prefrontal cortex develops between the age of 20 and 24. So that means it develops late in the late adulthood. So that means whatever your seniors have told, that means this is the component which governs, if you are looking at these functions here. So they govern important functions, executive functions. So that is the about the development of this DLPFC, that is the dorsolateral prefrontal cortex. One important aspect about this component, this part, it does not receive any sensory information from eyes and ears. So that means eyes and ears do not directly contact this part. Or it will not send impulses to the motor commands to the muscle. Neither it is connected to the sensory areas, nor it is connected to the motor area directly. Indirectly, yes. Directly, no inputs. And what it receives, or it talks to only bosses. Who are the bosses? The association areas. So that means it talks to the sensory association area, it talks to the motor association area, and it brings the information from them, and then it directs them, or it helps them to perform certain actions. So that means it receives inputs and gives output to the association cortex. That's one part. This part of the brain is involved in halting or pausing and choosing actions. And this is also important for retaining certain information for a period of time. So that is holding information in mind. That is what we call it as a working memory. Say, for example, somebody tells you about the telephone number or something. What you do, or your own roll number, you just say that you try to remember that particular thing, and you write it, and then you forget. So that means working. That is called a working memory. So usually the best example is remembering telephone numbers. Nowadays it is very difficult to remember because of the mobiles. So we have a 10-digit number and difficult to remember. But if it is a small thing, so we try to retain that information, and then we suppose if I go to a supermarket and I try to compare between the prices of two commodities. Say, for example, I am trying to buy a shirt, and when I'm trying to see the shirts of different brands, so then suddenly I just try to compare that. I hold the information about the cost of that particular shirt, and entire features of that particular shirt and entire features of this shirt I compare. So that means for that reason you require to hold that information. That is what is called a working memory, and that working memory is for comparison and then planning, and to see that which one I like, which one is my preference, like that. That is bringing about the action. So now injury to this part or lack of development of this area causes problems with the working memory. I have mentioned about what is working memory. I mentioned it's loss of the problems with working memory. He is not able to hold the events or memory, and he will have a problem in sequencing events. That means synchronizing the temporal synchronization of the event or a spatial synchronization of the events is not possible. Then suppose if he is having certain issues. Say, for example, if a particular work, a particular program or particular event you are planning, it did not materialize because suppose if there is a sudden electricity failure. And if there is a sudden electricity failure, you try to look into something else, what is happening to the generator set and whether it is working or not. So that means plan B options. The plan B options are to be searched and they will. So it does that. And it also controls the individual in all aspects. That means restraints. What I want to say that restraints in doing certain actions, whether it is really required or not required, whether it is socially acceptable, whether it is appropriate for the time, whether it will give you a fruit or result. So those all things are evaluated. So that means self-control or self-restraint is possible. The another thing is attention to perform a particular action or particular event. So that is to be given. These are all called executive functions. So that means dorsolateral prefrontal cortex is the seat of executive functions. Now, coming back with the medial prefrontal cortex. The medial prefrontal cortex is Brodmann area number 10. This is a Brodmann area number 10. And this would communicate with all the suppressor areas. So now I am using these S as a suffix. They are 8S, 24S, 4S, 2S, and 19S are the suppressor areas. These suppressor areas are coming here to the frontal side, and they try to inhibit these things. That means again they are putting the restraints. From area there are afferent inputs, or they have connections with the 8, 24, 4, and 2, and 14. Then it will have a connections with the eye field. That means this is the 8th area, and this is connected to this striate area. This is the visual area number 18. Now this is also connected to the temporal lobe. temporal lobe, area 44, 44 and 47. This is connected here, pass to the area number 38, and also receives inputs from 18. So that means this receives from the visual area to the auditory area. That means it connects both the visual and the auditory areas. So now this one will process the objects. So that means the visual or the auditory object. So what is auditory object? Auditory object is if something rings. Say for example, if a telephone rings, we know that by the sound of that we will say that it is a telephone. If a bell of a temple, bell in a temple rings, so you will know that it is the bell which is being ringing or the producing the sound. So maybe church, something like that we can identify, or some vessels are falling in your home and that are opening up the door. Those object, the processing, that means by the sound we can say that this is the sound of that particular object. Now, what happens when there is a lesion of the medial prefrontal cortex? What we will have the object agnosia, what is called a visual agnosia. So that means in the frontal eye field. So now in this area that is being processed, and what they will see, they will see the object. They will see the object, but they will not be able to identify. That is agnosia. That is not able to identify these things. Stereognosis, so that means identifying the object by somesthetic sensation. Similarly, this is the visual agnosia, not able to identify by the visual. Visually you are seeing, but you don't know the object properly. This is called a visual object agnosia. There is another thing. There is, because it is one-sided, that is why we will get an object vision hemianopia. So that means whether it is a temporal area or the nasal area, so that type. Similarly, we have the auditory object agnosia. Particular sound is produced by what? Maybe birds singing, so you will not be able to identify that it is from the birds. Orbitofrontal cortex connects to thalamic nuclei, temporal cortex, the limbic parts, amygdala, hippocampus, hypothalamus, anterior cingulate cortex, and somatosensory association areas. So even the motor association areas. So it will connect to that. And lesions of this orbitofrontal cortex will produce a disinhibition syndrome. That is a release phenomena. He will be just don't care master. So now, and at the same time, he will manifest with inappropriate social behavior. And emotionally, he is not stable. He is always fluctuating. And he does not have the ability for judgment, or he loses the ability for thinking and judgment. And he can be easily distracted. So these are some of the abnormalities associated with the orbitofrontal cortex lesions. Now coming back here, what are the connections of the prefrontal lobe? I have just summarized them here. So these are the connections associated with the thalamus. So that means whatever coming from thalamus, that is, so we have a two group of thalamic nuclei, one medial thalamic nuclei. This is M is the medial thalamic nuclei, and the medial thalamic nuclei communicate with all the areas of the prefrontal cortex. So dorsomedial nucleus. This is M. M is the dorsomedial nucleus. 8, 9, 10, 11, 12. 8, 9, 10, 11, 12 areas. So they are there. And it also communicates with a cingulate gyrus. Cingulate gyrus. This is a cingulate gyrus. This is the area number 24. Area number 24, anterior cingulate gyrus. And it receives inputs from hippocampus, mammillary body. Yesterday you saw that is a part of the peptide circuit. That means where anterior thalamus comes in. Anterior mammillary body, this is the hypothalamus, then this is the anterior part of the thalamus, and then with the cingulate cortex, and part of this thing entering into the 32. Then prefrontal cortex, thalamus, caudate nucleus, motor cortex. So it is a closed loop. That means you may start from anything from the motor cortex, caudate nucleus, the prefrontal cortex, thalamus, the caudate nucleus, motor cortex, caudate nucleus to thalamus and to the motor cortex. This is a closed loop which we have seen in the basal ganglia. So that is one of those connections, because that will try to plan the actions, plan your motor actions. That is the one component here. This is a closed loop. So then we have other connections like the prefrontal cortex that will reach to the thalamus, the interlaminar nucleus. And this interlaminar nucleus reach to the pan-cortical areas, entire cortical, these things, for easy synchronization and arousal response. So that is another part there. So these are thalamic related connections. Then intercortical connections. So that means from one side of the cortex to the other side of the cortex, they are connected. So that means area 32. Area 32 is connected with 8, 24, 4, 2, and 19. So that means this is 4 here, this is 2 here, this is 8 here, then 24 is here, and 19 is coming here in the back. Frontal eye field to area number 8, that is the occipital cortex. And I have mentioned about these are interconnected, and the ablation of this area I have already mentioned produces a visual agnosia, object vision, hemianopia. That's what I mentioned. Then we have area 47 and 44 and 47 pass on to the temporal lobe here. They will form the part of the amygdala and hippocampus circus. So area 38. So now they somewhere here 38 comes, so that they become the part of the amygdala, hippocampus, and the limbic system, which also receives inputs from 18. So this also receives from area number 18. Going further, then efferent connections. What are the outputs from the prefrontal cortex? The outputs from the prefrontal cortex will go to area 8 and the 24. This is 24. And then to the caudate nucleus. So this is the all inhibitory to caudate nucleus. The 8, 24, they will inhibit the caudate nucleus. Frontopontocerebellar connections, area 10. From area 10, they will go to the tegmentum and the pons. And the pons, they will go to the cerebellum, especially for the motor coordination, for the motor action through the reticular system. The frontopontocerebellar connections. The frontotegmental connections from the frontal, this is the area number 10, to the tegmentum here in the midbrain. Or frontothalamic area. So that means from 9 and 10, it comes to thalamus, this part of the thalamus there. And then to the ventral nucleus of thalamus and the medial nucleus of the thalamus. That means the anterior thalamus and the medial nucleus of thalamus, they will inform. So then interthalamic activity proceeds. Then frontotegmental, that is a reticular component, that is also achieved. So then it also gives to the mammillary body. So then the area 13 along with the hippocampus, uncus, amygdala to the mammillary body to the hypothalamus. So that means hypothalamus is connected through this mammillary body. So these areas, you have all the different connections going up here. So you can just see that this is one area 38. Area 38 is coming here, and you have these area number 8 is going to 18 there. From 18, it is coming to 20 there. Then this becomes a 38. This complex, that is a temporal lobe complex. Summary of the connections, because I have mentioned about the connections, I just briefly mentioned how it is connected. All things are bidirectional on both sides. Connected to thalamus, the medial nucleus and the anterior nucleus. Connected to hypothalamus via mammillary body. Connected to the visual area, number 18. Number 17 is the primary visual area. So it is a secondary visual area that we'll talk. Then temporal lobe, it is connected to the hippocampus, it is connected to the amygdala body, and it is connected to the brainstem through the tegmentum and to the pons, and it is connected to the cingulate gyrus. It is already I mentioned, it is connected to the hippocampus and amygdala, and it is almost connected to entire all the association areas which I have not mentioned. Maybe I will put all the association, all other association areas. Thus, it is linked to all the activities so that it can perform the intellectual activity, and it can have a personality built in, and it can bring the emotional aspects, maybe emotional exteriorization or the effects, and it can be able to think and judge and plan and execute the action. These are the summary of the connections. Now coming back, what happened when the frontal lobe was there? A lot of experiments were done with the ablation studies in monkeys. These are some of those studies I mentioned. These monkeys were removed the frontal lobe. Then after the operation, the monkeys were set aside, and these are the observations they made. So once the frontal lobe was removed, ablation means removal. Once it is removed, what happens? Initially, there was a apathy and sluggishness of the actions in case of the monkeys. There is a total lack of interest in the surroundings. It does not care what is happening around, and it is sluggish, and it does not bother. It is just sitting quiet, and that is what. Then after some days, suddenly it became hyperactive. And hyperactive, that means it is moving in the cage incessantly like a coin, like a lion, like a caged lion. It is moving here and there and this side, that side, without any purpose. Usually the monkeys, they have a purpose when they move. So now without any purpose, they are incessantly walking. So that there is a hyperactivity, aimless hyperactivity. And they become violent often at night. So that is what the monkeys did. So this is related to the alterations in the activity of the area 13, hypothalamus and caudate nucleus are linked. So they saw that they are linked here when they are performing. Then second part, alteration in the emotional exteriorization. So what happens to these monkeys? So the monkeys were trained to differentiate the weight of the particular object, and they were differentiating the heavy weight and light weight. So now this particular thing was lost. This particular thing was lost after postcentral extirpation. And in prefrontal sections, again, they were not able to bring in they were becoming restless, and they were not happy that they were not able to identify. That is a part of the emotional exteriorization. Now, alterations in the social behavior. Usually monkeys are shy. They try to run away from the human or man. And when they approach, they will just run away. They will not be coming to you. Now this monkey, after these monkeys after the ablation, they lost that shyness. They were coming and approaching the examiner and trying to touch him, trying to look at him, and that is the type of behavior. So that means the social behavior is running away. Now they lost the shyness and the fear of a man, because they are afraid of the man, and that is what this thing. So no grooming or acts of compassion with others in the cage. Suppose if there are 2 or 3 monkeys together, so that means there is no grooming. You must have seen monkeys when they are sit together, they try to sit near. Sometimes they pick up some insects or some lice present in their hairs. They try to help the fellow being. So that is a sort of a grooming. So and trying to help each other. So that type of behavior is lost even with the others present in the cage. Sometimes what they happen, they consider the others do not exist. They walk over them. They try to snatch the food or bananas given to them, and they are reckless with these things. That means it's a total sort of a antisocial aspect of the monkeys. On the other hand, they are not aggressive. Only thing, they lost the social conscience. So they are not aggressive. They are not attacking, but they don't care. That is the thing. It does not matter to them. It does not matter to them. That's the thing. Then the fourth aspect is the impairment of the memory. They are not able to recognize, or they may not be able to think what has happened. Then they did not have the learning ability. And when area 13 stimulated, the heart rate and the area 13 in these monkeys stimulated, there is an increase in the heart rate and respiration. Okay, so that means that is otherwise the heart rate and respiration were this thing, and that area 13 will also maintain the autonomic activity of the motility of the GIT, motility is motor, secretomotor activity of the gut, that is also lost. The central vagus stimulation produced a circle of activity, or area of activity around area number 13. So these are certain areas. This area number 13 is designated for the autonomic activity. This is being brought through the amygdala, hypothalamic, mammillary body, amygdala, hypothalamic outputs. Now, then this is all about monkeys. So now in humans, the operations are done. Previously, they were practicing prefrontal lobotomy. And these patients, especially those who have a psychiatric disorders, where the not responding because nowadays it is not done. The previously it was performed the psychiatric disorder where they have become aggressive or they become antisocial. They try to do that after doing the prefrontal lobotomy, they observed certain things. So these are patients who are having intractable pain because of the terminal illness, because they are suffering from cancer or some other disorders, and they wanted to relieve them from the pain. So in that situation, they perform the frontal lobotomy. Lobotomy is not, it's just separation, cutting the connections. Lobotomy is removing the lobe. You just try to understand that component. So now, so they perform the frontal lobotomy, and it is a simple procedure, and they have a surgically you can do that. So then what happened? These persons, the psychiatric persons or intractable pain, they became cheerful, they become happy, and now they become less critical, because previously they were more worried, and they were sort of a suffering. No, so they became less critical, and they have the exalted opinions about their self. They felt better. So that is a overconfidence built in, but not true, because they have the exalted opinions, a false exalted opinion. So that is the overconfidence they developed. But these persons were not able to concentrate on anything, and can be easily distracted by even anything happening around. Even a mosquito coming there, and that will distract them, or anything. Usually we try to ignore certain things. That type of behavior was not present in these. And so they don't have any interest. They were just sitting at one place, and there is no purpose in life. That type of situation they observed in the prefrontal lobotomy individuals. This is in humans. So this is what happened with these are the list of observations they made in a patient with a prefrontal lobotomy, because this is one of the question you may get. So what is a frontal lobe syndrome or a prefrontal lobotomy? So the patient lost their ability to solve complex problems. The complex problems means what? You give him some mathematical aspects, just like multiplication of 2 into 5. Even that also he may not be able to perform, because that requires that particular logic to be developed. They were unable to join or string the sequence of tasks to reach complex goals. To achieve, even to achieve or go out of the room. To go out of the room, I have to get up, and from getting up, I have to go to the door, open the door, and then go out of the complex. So these are complex in the sense that they were not able to put all those sequence of events to perform the tasks. This is one thing I am trying to tell. So like that, we have several tasks in our life. They were unable to learn new things. One point. And they were unable to do several parallel tasks simultaneously. So that means we usually do parallel tasks. What I am doing here, I am trying to express to you, and at the same time I'm using the mouse, and I am trying to see the keyboard. These are all parallel tasks that I am performing. So they cannot do that. The aggressiveness was decreased. They become docile. And in general, they lost the ambition. They don't feel like having any aim in their life. Their social responses were inappropriate for the occasion. So that means if somebody is there is a condolence or a grief, then they may suddenly laugh at the situation. That is a totally inappropriate social behavior. So in that type of behavior is lost. When everybody is silent, they started laughing. So what does it mean? So that inappropriateness of the occasion, often including loss of morals. Morals means their sexual behavior and the social behavior, passing of the urine, stool, and sexual acts. They will they don't have a control, or they don't care about that. So they feel like passing urine, they just pass urine, no matter what it is, where it is, how it is. So that type of situation, and even with a relation of the sexual activity, because it's all suppressed, and they lose that particular moral or restraint, social restraint. The patients, when you talk to them, they talk well, and they are nice, and they comprehend the language, they understand the language, but they were unable to carry through any long trains of thoughts. They cannot take the strings of thoughts, and their moods are always changed rapidly. They switch from sweetness to rage. Sometimes they are nice, sometimes they become very violent or upset, they're crying or whatever, I don't know, anything may happen. So that means to have the exhilaration to madness, what is called a manic type of situation. The patients could also still perform most usual patterns of motor function, that means moving hands, lifting weight, taking the plate, but all of them they were doing without, say for example, they may open the book and they may try to open the pages, but they do not understand what the pages to be done and how to assimilate all that information. So that particular relevance or the purpose is lost. This is about the prefrontal lobotomy. Now I will just bring back the functions of the various parts of the prefrontal cortex. Here I have made the various parts and their functions in a bridged manner. Dorsolateral prefrontal cortex. This is what I mentioned, the dorsolateral prefrontal cortex. I shown there, Broadman area 9 and 46, the executive function, the self-control, working memory. The executive function brings about judgment, social balancing, and social restraint, and trying to be decide about plan the actions, decide about the action, and sequence about the actions. Then the frontal lobe, this is a polar area, the medial frontal area. So that will be concerned with the higher functions. That means maybe language, maybe the use of the particular words, and use of appropriateness or making appropriate behavior, and all those higher functions. So then they will think about hierarchical context. So how to respect a senior, how to respect a junior, and in what manner. So they can be able to narrate an event or produce an event. So this is the frontal pole. This is the function of the frontal polar area. The cingulate cortex, the anterior cingulate cortex. So this is associated with the pain connections. The feelings, that is the emotions, the pain, the motivation, and self-monitoring, the self trying to understand oneself. So these are the functions of the anterior cingulate cortex. Then orbitofrontal cortex. So this is a sensory hub that is trying to put the sensory components. So here we have a number of choices, just like I'm giving whether to eat or not to eat, whether a particular food item you like or dislike, whether whether you want to at this point of time you want to have a cold drink or hot drink. So like that decision, this is a decision making. So that means a choice. So now trying to understand between the good and bad. So that is using the sensory components, and expecting something. So maybe you people are expecting something from your teachers. Similarly, the expectations come from the orbitofrontal cortex. So now we have the subgenual cortex. This is connected with the hypothalamus and the limbic system, and they will have a thought and feeling. This brings the thought and feeling interface, the bridge between the thought and the emotion, whatever we think and the emotion associated with that particular thinking. Then because it is connected with the hypothalamus, the sleep is controlled, the appetite. So the particular person with this, they may lose appetite. They don't care. They don't have the desire to eat. So that appetite and behavior exteriorization. So what is that behavior exteriorization? So that means the behavior is maintained. So that means we try to compose ourselves and try to be acceptable as for the social circumstance concerned. So now in that case, it may in the abnormalities, it is manifested as a depression, mania, or apathy, or whatever. So this one is a Broca's area is for the speech area. This is a language. Now this is in brief. I have made a summary of these things, the areas, and then their functions. I have just put them there. And now I'm going little further there. So now I have taken the frontal cortex, the prefrontal cortex functions. One, control of aggressiveness and inappropriate social responses. Then performing executive function, that means elaboration of thought. Prognostication, that means deciding of particular good or bad event. And then performance of higher intellectual functions. So that means bringing the knowledge and then trying to perform that act. So suppose you become a surgeon and you try to do that, all that intellectual functions. So those things are trying to diagnose a patient. This is one of the intellectual functions we learn through the whatever the knowledge we gained. So this is by the prefrontal area. And of course, there's a concept of working memory. Working memory is currently use the particular memory, and it is not stored. It is not stored there. It is just used for comparison purposes, and then it is erased. Then it has a goal achievement. So the directed to achieve goals or carry the actions through sequential thoughts to achieve goals. So these are the three major areas of the functions of the prefrontal cortex. So then how it controls the aggressiveness and inappropriate social responses. These two characteristics probably result from loss of ventral parts of the frontal lobes, the anterior part of the frontal lobes, the underside of the brain. This area is in association with the limbic cortex. So rather than of a prefrontal association area, this limbic area helps to control the behavior. So that means the behavior, that aggressiveness and inappropriate social responses, that is being controlled. So usually the frontal lobotomy, so the person loses the aggressiveness. So that means the frontal lobe is required for aggressiveness. In the other way, if I were to tell, suppose a person with a frontal lobotomy, he has become less aggressive, he has become docile. That means the frontal lobe balances between the aggressiveness and the placidness. So these two components, this frontal lobe is balancing, or is on this side, that it is producing aggression. Executive functions are achieved by three components: self-control, working memory, cognitive flexibility. Self-control is the aspect of inhibitory control that involves resisting temptations and not acting impulsively or prematurely. We have a working memory, holding on the information I have already mentioned while solving a problem. Then cognitive flexibility, the changing of the perspective for approaches of the problem, and a flexibility in adjusting to new demands and rules. That means we have to change the decisions as per the requirements. Suppose if I am going out, there is a rain, suddenly I have to take out the umbrella and open it up. So this is a cognitive ability to guard oneself. So that means changing perspectives to approach a problem, and that is one, switching between the tasks. So that is these are the things. And now I am just taking about self-control. So now in the self-control, what happens? Being able to control attention, behavior, thoughts, and or emotions, and somehow not submit a strong internal urge of temptation. Usually we have a temptation, but we stop that. So now if we don't develop the inhibitory control, we are controlled by the impulses or the habits. The inhibitory controls make possible to change our behavior, break habits, and we respond appropriately in the normal extent. Our behaviors are mostly reflexive, and it is controlled by the dorsolateral prefrontal cortex. So now this dorsolateral prefrontal cortex, this way we will derive what is called a delayed gratification. So now dorsolateral prefrontal cortex is not working. If it is not working, or it has not been trained, there is usually loss of self-control, and you may have problems associated with the self-control. Now this is one of the classic Stanford study. In this, Dr. Walter Mischel, what he did, he conducted this study, and he gave what Marcel knows are the chocolates. He gave the 4-year-old children, he gave chocolates, or he gave the chocolates, he offered chocolates, and he said that those who resist taking one, after some time they would be given an additional one, that number 2. Then he studied the group of boys or children, who some children took immediately, some children resisted the temptation. And he studied those students who resisted the temptation and who acquired two chocolates or 2 Marshall Moss in this order. Then he studied in over the year of time, and then he examined them, because he started this study when they were 4-year-old, and he continued it further. And so he found that these children did better in their life. They scored higher on SAT exam. They had a better social skills. They had a greater self-confidence and self-esteem, and they were more mature, and they coped with the stress better, and they have a tendency to plan ahead, and were more likely to think about the decisions instead of acting on. They also had a fewer behavioral problems. So that means they were okay, perfect. By the time they grew into adults, because it's a longitudinal study, there was no question of the importance of this skill. These kids who could wait were less likely to have this drug abuse or alcohol or drug abuse. And they had a very decent job, and they enjoyed their job and their relations. So now, this is one of those great studies. I've just abridged that study, and it is just thinking that how the self-restraint, self-control behavior in the prefrontal cortex would help. So now this is especially the dorsolateral prefrontal cortex. If it is not working, usually we have these problems, especially with the self-restraint. Then going further, because this is also concerned with the working memory. So just to one word, maybe Saturday I will be talking about memory, but working memory is a component of the prefrontal lobe. So now it has two components in the working memory. So that is the holding of the information in the mind. There are verbal or a word or a spatial, the relations of the objects in space. When we have a good working memory, we get the connections and we put them together, and then we string them together. So now it is in connection with the working memory, is connection with the Broca's area, and it is necessary for expression of the language. Expression of the language. You can combine, compare, and contrast. Is attaining goals for organizing sequences and sequences get together. So now, what happens without a good working memory? It is hard to see big picture and how parts are interacting to form. The arts, music, literature all require working memory for their creation as well as their appreciation. So this is what the function of the working memory. When DLPFC is not working, is not trained, usually this is lost. So we can improve this working memory by meditation and attentional training to develop this area of the brain. So that means what I advise, why I am taking about working memory for all you guys. So because this is important to have our working memory intact to achieve your goals, because you achieve the good scorings for the coming. So that means try to have spend some time for meditation or attention training. So some of these doctors, they try to stimulate the brain stimulation, and when they did that, the working memory improved. Okay, I'm not going into the detail of that component. Now the flexible thinking. The flexible thinking is a alternate thinking out of bracket. So this is the it is learned. This thinking is learned at a later age than first two. So that means it comes even after 24, 25. Maybe sometime it may take a longer time. So maybe when you are exposed to the different type of circumstances, how to think about laterally and bring in out of bracket. This is the ability we are using when we look things in a different point of view, different perspectives. We can change the perspective in space. What would be this like? Just like what the particular in space, what would be this look like if it is in blue, or if the couch were over there, what it would be. So that means in a house when they are setting particular thing. So it is just to understand the perspectives. To do this, however, we need to set aside or inhibit the way we look at things. So that means we try to suppress this different viewpoint, and this is what we call it as a maturity, we say, while setting aside the things, approaching the situation, understanding an issue. Problem solving often requires us to imagine new possibilities, to think outside the box. So that is the what is called a flexible thinking. Now we come back with the directed to achieve goals, or carry through the sequential thoughts to achieve goals. Although people without prefrontal cortices can still think, they think When there is a removal, Mr. Gage was thinking, but he does not have purpose. They show little concern, concerted thinking. They planned or concerted thinking one after another. There is no logical sequence of the thinking. So it's only for a few seconds and again they left it. So they cannot hold on to for a long time. Patients without prefrontal cortices are easily distracted from their central theme of thought, whereas people with functioning prefrontal cortices can drive themselves to completion of their thought and goals irrespective of the distractions. So just like you people now with the COVID-19, so you are again sitting on and trying to achieve your goals. So that is the goal you have set for yourself. DLFC functions, executive functions, planning, organization skill, abstraction, that is narration, the motivation, attention, cognitive flexibility, predict consequences, what is happening, prognosticability, and emotional effect, problem solving in terms of the decision, calculating, thinking, then the eyeball movements, the movements of the eyes. So these are DLPFC functions. So these are orbitofrontal functions. These orbitofrontal functions are social functioning, empathetic, civil and social activity, the personality, and the response to social issues. Then if there is an impairment or the lesions of the orbitofrontal cortex, we have a irritability, loss of tactness, and the fatuous euphoria, the false euphoria, the impulsivity, and undue familiarity. So undue familiarity is a condition what is called a déjà vu syndrome. Déjà vu syndrome. He tries to see everything very familiar. Very familiar. So this is one of those orbitofrontal cortical déjà vu. DEJAVU, déjà vu syndrome. The mood disorders, because of this thing, labile, they are very unstable, manic, and obsessive compulsive disorders. This is about orbitofrontal. Just to summarize the function of the prefrontal cortex, we have executive functions, the emotions, the intellectual ability, the motivational drive, involvement of surroundings, discrimination and judgment, the social behavior. So the memory has come twice. No, the memory. So the working, especially the working memory. So these are the primary or main functions of these things. You can highlight these functions in subsequently. Now, this is a frontal lobe syndrome. It is one of those questions, short note questions you may get. So if you can just know focal neurologic deficits, the frontal lobe personality, apathy, euphoria, irritability for short time, and social inappropriateness. That is one. Not able to perform the cognitive, that means executive functions. Judgment is not there. He cannot take a decision. He's totally indecisive. He cannot attend, or he cannot be attentive. He has no working memory, and he cannot put things in abstract form. So there are also behavioral abnormalities depending upon the patient to patient. So now keywords for today's topic: working memory, parts of prefrontal cortex, frontal lobe syndrome, orbitofrontal cortex, dorsolateral prefrontal lobe, apparent connections with the prefrontal lobe, efferent connections, the frontal lobotomy or frontal lobotomy. Now I want to add déjà vu syndrome. Try to look into that. Tomorrow I will take about the speech and speech disorders.